What if the surgery your doctor is recommending is the last thing your body actually needs? I'm a doctor. I've spent over 10 years focusing specifically on the health of people over 60. And right now, I'm going to tell you something that most physicians never say out loud. There are 5 common surgeries that I see recommended to older patients every single week. And they are 5 surgeries that I would fight hard to keep my own mother away from. Stay with me, because what you're about to hear could protect you or someone you love from a decision that looks right on paper but goes terribly wrong in real life. My name is Dr. Isabel Greer. I've spent more than a decade working specifically with patients over 60, in hospitals, in clinics, and in conversations that most doctors simply don't have time for anymore. I've seen what happens after surgery, the charts, the complications, the nursing home placements that nobody warned the family about. I've held hands and answered hard questions that should have been asked before the operation, not after. This video is for you if you're over 60. It's for you if you have a parent, a spouse, or a friend facing a big surgery recommendation. It's for you if you've ever said yes to a procedure because you trusted your doctor and didn't know what else to ask. Quick disclaimer before we start. Everything I share here is for educational purposes only. This is not medical advice, and it does not replace a conversation with your own doctor. What I can give you today is the information and the questions that will make that conversation so much better. Now, let's get into it. Before I give you the list, I need you to understand one thing, because without this, the list won't make sense. Surgery after 60 is not the same as surgery at 40. I don't say this to scare you. I say it because it's basic biology, and almost nobody explains it clearly. Think of your body's recovery system like a phone battery. At 40, you start the day at 100%. Surgery drains maybe 60% of it. You recharge overnight. By day 3, you're back. At 72, you might start the day at 55%. Surgery drains the same 60%. You're already in the red before your body even starts healing, and recharging takes weeks, not days. There's a concept in medicine called physiological reserve. It means how much your body has left in the tank when something stressful happens. By the time most people reach 70, that reserve is smaller, not because they've done anything wrong, but because that's how biology works. A 2023 study published in JAMA Surgery tracked more than 15,000 patients over age 70 who had major surgery. Nearly 40% showed measurable cognitive decline 6 months later, not just temporary confusion, lasting changes in memory and thinking. And it's not just the brain. Muscle loss in hospitalized seniors can reach 3 to 5% per day of bed rest. A 75-year-old who spends 2 weeks in bed after surgery can lose nearly half of their functional muscle strength. And unlike a younger person, they may never fully get it back. Comment biology below if this already changes how you think about surgery decisions. I want to tell you about a woman named Patricia. She was 73, active, sharp, funny. She went in for a knee replacement, a technically successful surgery done by a skilled surgeon at a good hospital. The procedure itself? Flawless. But Patricia developed post-operative delirium on day 2. She didn't recognize her husband. She became convinced she was in danger. She tried to leave. They sedated her. The sedation made her more confused. The confusion kept her from doing physical therapy. Without physical therapy, she developed pneumonia. The knee healed perfectly. Patricia spent 4 months in a rehabilitation facility. She came home a different person, quieter, more fearful, less herself. Her family says the surgery added years to her life, but took years from her living. Hold on, because this doesn't mean surgery is always the wrong answer. It means we need to talk about it honestly. And that starts with knowing which 5 surgeries carry the highest risk of this kind of outcome. Surgery. Number 1. Hip replacement after age 75. Let me be clear. I am not saying hip replacements are always wrong. I'm saying the math changes dramatically after 75. A 2024 study from the British Medical Journal followed over 8,000 hip surgery patients over the age of 75. Within 1 year, 28% had not returned to their previous level of function. 15% ended up in nursing homes. The surgery had a 95% technical success rate, but the life success rate? Much lower. And here's what most surgeons don't say. In many cases, the pain driving the decision can be significantly managed without surgery. Targeted physical therapy, pain management protocols, mobility aids, simple home modifications. I had a patient, I'll call him George, 76 years old, who was told he needed a hip replacement and should schedule it within 2 months. He came to see me for a second opinion. We tried an aggressive 8-week physical therapy program instead. George is 79 now. He still has arthritis, but he walks to the corner store every morning. He plays cards with his friends twice a week. He never had that surgery. Would everyone have George's result? No, but the conversation deserved to happen. If you or someone you love has been told they need hip surgery, stay with me. I'm going to give you 7 specific questions to ask before you agree to anything. Surgery, number 2 and number 3, emergency colon surgery and bowel obstruction repair. These two belong together because they share something critical. They are often presented as no-choice emergencies, when in reality, there is frequently more time to think than the urgency in the room suggests. Emergency colectomy, removing part of the colon, in patients over 70 carries a mortality rate between 15% and 25% in most studies. That means, in the worst-case group, 1 in 4 patients doesn't survive. For those who do, the recovery often involves temporary or permanent colostomy bags, months of restricted diet, extreme fatigue, and a high rate of additional surgeries. Here's what I want you to know. Many situations that are labeled as surgical emergencies can actually be managed, at least initially, with antibiotics, bowel rest, and careful monitoring, aggressive medical management, draining abscesses through small procedures instead of opening someone up. This doesn't work in every case. Truly dead bowel, that's a genuine emergency, and it needs the operating room fast. But not every bowel problem is dead bowel. I saw a patient, a 71-year-old retired teacher named Evelyn, who came in with severe diverticulitis. The surgical resident on call wanted her in the operating room within the hour. I asked if we could try aggressive antibiotic therapy and close monitoring for 24 hours first. We did. The infection responded. Evelyn went home 5 days later without surgery. That was 3 years ago. She's still managing with medication and diet. Her surgeon later told me he was grateful someone pushed the pause button. The lesson? Unless you're actively deteriorating, ask for the conservative option. Push for it. Demand to know why it won't work before you sign a consent form. Surgery number 4, ulcer perforation repair in frail patients. A perforated ulcer sounds terrifying, and it can be, but what most patients don't know is that the outcome data for surgery in elderly patients is sobering. Patients over 75 with perforated ulcers who undergo emergency surgery have mortality rates between 30% and 50% in many studies. Even the survivors often face prolonged intensive care, ventilators, repeat operations. There is emerging evidence, still being studied, that in very select patients, conservative management with powerful antibiotics and drainage procedures can be an option. It's not right for everyone, but it's a conversation worth having. The key word I want you to take from this section is frailty. Ask your surgeon to calculate your frailty index score. This is a real, validated medical tool that predicts surgical risk in older patients. It's simple, and it takes about 5 minutes. It gives a number that can genuinely change the recommendation. If your surgeon looks at you blankly when you ask about the frailty index, that's important information. You may need to ask for a geriatric specialist. Comment frailty below if you're going to ask about this at your next appointment. I want to see how many of you are going to use this. Surgery, number 5, appendectomy after age 80. For a 30-year-old, appendix surgery carries a mortality risk below 1%. For a patient over 80, that number can reach 5 to 8%. Why? Because elderly patients often wait longer before coming in, the appendix has already ruptured, and sepsis develops fast in an older immune system. But here's the piece most people over 80 are never told. In uncomplicated appendicitis, antibiotics alone work about 70% of the time. A 2023 Scandinavian study confirmed this. In elderly patients with non-perforated appendicitis, the majority resolved without any surgery at all. This is not the standard of care everywhere. Many surgeons will push directly to the OR, but you have the right to ask, is this uncomplicated? Could we try antibiotics first with close monitoring? If there's already perforation, if there's an abscess, if you're actively septic, that's different. The situation calls for surgery, but if it's caught early, ask the question. I think about a woman I'll call Rose. She was 82, came in with abdominal pain. The surgical team said she needed her appendix out. Her daughter, who happened to be a nurse, asked about the antibiotic approach. The team tried it. Rose improved within 48 hours. She never had surgery. She went home and baked her grandson's birthday cake the following week. That question her daughter asked, it changed everything. Your 7-question checklist. Before saying yes to surgery, print this out. Stick it on your fridge. Bring it to every appointment. 1. Ask your surgeon to calculate your frailty index score. If they don't know what that is, ask for a referral to a geriatric specialist. 2. Ask for baseline cognitive testing before any surgery, simple memory and thinking tests. This protects you. If something changes after surgery, you have proof of where you started. 3. Ask directly, what are the non-surgical alternatives and why are we ruling them out? Make them explain it. If they say there are none, get a second opinion. 4. See a geriatrician, not just another surgeon, for that second opinion. A geriatrician's job is to think about the whole elderly patient, not just the one problem surgery can fix. 5. Ask about the POSM score, a surgical risk calculator specifically designed for older patients. It factors in your age, your health conditions, and the specific surgery. It gives you real numbers about real risks. 6. Update your advance directive with specific language. Write down, if surgery would likely result in nursing home placement, I choose palliative care. Or, I prioritize my mental sharpness over a longer life. Make your values clear before someone else has to guess. 7. Demand a family meeting with the surgical team. Ask this exact question: what percentage of patients my age having this surgery end up in a nursing home or never return to independent living? You deserve a real answer, not reassurance. Let me tell you why I'm so passionate about this. My own mother is 78 years old. Last year, her orthopedic surgeon recommended spinal fusion surgery, 6-hour procedure, months of recovery. He was confident it would help her pain. I sat with her at the kitchen table that evening, and we went through everything I just shared with you. We calculated her frailty index together. We talked about what she actually wanted her life to look like. Not just longer, but better. She wanted to keep walking her dog in the morning. She wanted to cook Sunday dinners. She wanted to remember them. We got a second opinion from a geriatric rehabilitation specialist. She recommended a combination of targeted physical therapy, steroid injections, and specific movement modifications. My mother did not have that surgery. 15 months later, her imaging looks the same, but she is walking her dog every morning. She cooked Christmas dinner for 12 people last year. She is still fully herself. Would surgery have given her less pain? Maybe, possibly. But at what cost to everything else she values? She made a real informed choice. That's all I want for you. Quick recap of everything we covered. Surgery after 60 carries fundamentally different risks due to reduced physiological reserve. The 5 high-risk surgeries for older patients: hip replacement over 75, emergency colectomy, bowel obstruction repair, perforated ulcer surgery in frail patients, and appendectomy. Over 80 non-surgical alternatives exist and are often under-discussed. 7 questions to ask before you ever sign a consent form. The frailty index, the POSM score, and a geriatric second opinion could change everything. If this kind of honest, practical information is what you're looking for, the stuff doctors discuss among themselves but don't always bring to the patient, then subscribe. That's exactly what this channel is here for. And please, share this with someone over 60 in your life who might be facing a surgery decision right now. This information only helps if it reaches the people who need it. Take care of yourself. Ask the hard questions. You deserve honest answers.